Whose radar will this be on?
So fluid overload, it depends. I mean, it can happen with the best will in the world, but I would say that if it's happened because of an error and it's got nothing to do with blood transfusion, then it should be reported like any other clinical incident. So obviously you can overload a patient with blood, you can also do it with non-blood fluid as well. And sometimes the cases that we see that are reported as TACO have an element of both. They do have an element of both, it just means that the imputability is reduced. That means that I can't blame the blood transfusion entirely on the patient being overloaded. So if the patient has a comorbidity that predisposes them to overload, such as cardiac failure or renal impairment, or the patient's had non-blood fluids, then the blood transfusion is only partially responsible. But I think to answer the question, if a patient has only had non-blood fluid and it becomes overloaded because of an error, then yes, that should be reported as a clinical incident.
Thank you so much. Nikki?
Yeah, so this one from somebody in the chat. So I think it's related to your presentation, Sharran. So it's talking about, I think, a particular case. So it says, why 12 hours after a transfusion if a patient pathway started in A&E, then moved to AMU or any of the acute wards, and then moved up to ICU all on the same day and develops TACO, staff are not connecting the dots about previous transfusion. So I think that was related to your cases.
Yes, and I think that it's a very good point, and I think because we are never very sure about the start and stop times, or the fact that if a patient has just gradually had lots of blood over a long period of time, what do you call post-transfusion? Where did it start? Where did it stop? And I think that's one of the elements of flexibility that was built into our reporting, that SHOT, unlike other haemovigilance organisations, accepts cases between 12 and 24 hours, because we can't really be sure about that kind of grey area sometimes. So if you believe a patient has TACO, then please do report it.
So we have a second question on the Q&A. So if a patient has a history of TACO and there is a request for a number of units, does the laboratory have to inform the clinician requesting of the previous risk, or is out of their remit?
I think I would go back to what I said when I answered the first question about it being with the responsibility of the person authorising the transfusion. They should know enough about that patient's history to make a decision about the current transfusion decision.
Sharran, can I add something there as well?
Yes.
Just briefly, I think that's really important, actually, and I think it comes down to a degree at the time, particularly with the authorisers, to emphasise that there needs to be a review of the effects of the transfusion and an assessment, which may provoke a further assessment in terms of the repeated number of transfusions, and that may help overcome the fact that for example, the nursing staff may not feel that they have the ability or the authority to decide whether to give or not, and would seek secondary advice.
Super, thank you. I'm going to merge a couple of questions together because they are very along the same line. So the first part is, when a pulmonary WEG can't decide between a TACO and a Trali or both, what do you do next? And then the second part of that is, how do you decide regarding investigating blood donors if it's a suspected Trali? So Puneet, I don't know if you want to take a Trali related one.
Yeah, sure. I mean, I can answer the first part of that question. So Andrew and I, we do get a lot of cases for review, and clearly TACO and Trali are two different conditions with completely different pathophysiology, but there's a lot of overlap in the risk factors, and a lot of our patients have risk factors for both, have comorbidities and so on, and also present very in similar fashion clinically with respiratory failure. There are some subtle differences that we try and tease out sometimes, the appearances on CT scan or chest X-ray. But what we found the most useful parameter in distinguishing these two is the response to diuretic. And in general, if it's fluid overload or TACO, these patients do better. They get better with diuretics, and the sort of time course of respiratory failure improves much more rapidly than does Trali. So, but having said that, there are often, patients have not read the textbook and decided I'll have TACO or I'll have TRALI. There's a lot of overlap. And we are, in some cases, unable to distinguish between TACO and TRALI. And therefore, having that category of TACO and TRALI is a very real world kind of situation where we put those patients in.
Yeah, I think that is coming back to what I was trying to say about deciding whether it's TACO or TRALI is probably the wrong question to ask. I kind of think of the physiology. So patients may have had too much fluid, and they may have had an inflammatory insult as well, making it difficult for them to operate the transfusion. And I think it's not helpful to decide which was the most important thing. Both factors happened. And the formal classification does allow for this uncertainty. In the revised consensus classification, there is an entity called TACO, and TRALI cannot be distinguished. And in short, we interpret that as meaning that both the TACO and the TRALI criteria were satisfied. And then the other approach, if we're not able to distinguish, of course, is the case is called TAD.
It is worth noting, isn't it, Tom, that we're really dependent on the information that's provided.
Yeah.
And you highlighted that in terms of the classifications that eventually come into TAD-C or TAD-IC.
I'm not going to say very much about how we decide which donors to investigate. If you're really interested, you can read my paper, which has just been published in Transfusion Medicine. Essentially, the way we approach it, and this is different in different parts of the UK. The cases are reviewed in England. Cases are reviewed by an expert panel, and this is not the expert panel is not part of SHOT. It's part of the blood service. Although many of the people on this panel are also on both committees. And the decision for blood services is slightly different. So it's not so much, is this case TACO or TRALI? The decision really is, are we suspicious that this case might have been caused by antibodies in a donor, and we should go on to identify the donors. The donor investigation takes several months to come back. And so the investigation of donors is primarily the investigation of cases is primarily to try and identify donors who might be at risk of causing another reaction. The results come back too slowly to be of much use to help you managing the individual patient. The exact basis on which we decide which cases to identify is slightly difficult to describe. I think it would be fair to say, and that's why we have an expert panel with multiple experts, and it needs to be a unanimous decision if we decide not to investigate a case that has been referred.
That's great, thank you. I'll hand over to Vera for the next one.
Yeah, thank you. So we have another question on the Q&A. So have you tried therapeutic bleeding in a TACO?
I just missed that question. I'm so sorry.
It is, have you tried therapeutic bleeding in a TACO?
No, I don't believe that's right. I think it very much depends on. I don't do it, but
yeah.
Go on.
Well, I think not in TACO cases, but there are. I mean, there isn't the other SHOT category of over-transfusion. Some of these over-transfusion cases may also develop TACO-like features, and yes, and people who have been over-transfused may be venesected, I suppose.
Yeah, but it's worth highlighting that this.
You know.
Sorry, Shan. Yeah, I would just say it's worth highlighting that obviously the mainstay of treatment for a TACO in terms of the clinical measurement of management of stopping the fluids would obviously be oxygen therapy, and obviously in the more recent years, positive pressure ventilation, even it being non-invasive with the use of CPAP, is by far the most effective, together with diuresis.
The next question I think is probably really pertinent with lots of people implementing new IT across the UK and further afield potentially. So the TACO checklist is difficult to implement as most of the hospitals now have EPR systems in place, which is not sophisticated enough to add in the checklist. Have you got any advice or suggestions if people are struggling to try and get that checklist in their EPRs?
I think we have seen some really good examples of where that has been achieved in various organisations. I'm not sure whether we specifically have those examples available in our resources on the shop's website, but I do know that there are some that have certainly achieved that, and it's been very successful for them. I remember, was it a year or two ago, somebody actually won one of the abstracts, didn't they, for exactly that, and it was a really very good example. So they do exist, and maybe we could think about creating a resource of practice that others could refer to if it's useful to them.
Yeah, great, that's great, thank you.
So we have another question. So do you need fresh plasma or serum samples for trial investigations? And if it's always needed, is it possible to use archive samples from donors?
It depends whether you're talking about the recipient or from the donor. So the samples that we need from the recipient, the most important is in fact an EDTA sample, because the purpose of the sample is to establish the HPA and human neutrophil type of the recipient. From the donor point of view, we are in principle able to use frozen archive material. The difficulties with that is, first of all, the archive material is quite small. And so we may not have enough serum in the archive. And the other reason we ask for fresh samples is that the archive sample is primarily intended for long-term storage to look for infections. And so we are not really supposed to use it for trial investigation. We have recently argued in NHSBT that we should be able to use those, because it is a patient safety issue if the donor has got antibodies, and so it's recently been changed that we are able to use archive sample if the donor doesn't respond to contact, and there is a very high suspicion that the case was caused by antibodies in the donor.
Thank you, Tom. That's great. So next question, do we have a paediatric TACO risk assessment? Are the risk factors similar to adults? I don't know if I want to, can I hand that one to you, Sharran? Thanks.
I don't mind taking that one. Well, it's something that we're asked quite a lot, actually, and I think we maybe did answer this in our FAQ that we did for the TACO MPSA alert. But to just summarise that, so we have an adult one, and that adult risk assessment is based upon the thematic analysis of a large number of adult cases. So we know that there are certain things that crop up all the time that are associated with patients who have TACO reported. So that's where they come from, and I think that's pretty well established now. Now, intuitively, you would think that the paediatric population might have similar risk factors, but it is a very heterogeneous population. So, does a 15-year-old have the same physiology as a neonate? Probably not. And the problem we have, of course, is that we have very many more adult cases than we do paediatric cases. We only have a handful every year, and sometimes, just in single figures. And even if we went back many, many years into the data that we have within SHOT, we probably still don't have enough to do the same level of evaluation on that. Now, we've had a meeting very recently, actually, amongst our paediatric colleagues who work on the paediatric chapter for SHOT, the SHOT report. And we are thinking of doing some collaborative work, perhaps, with international haemovigilance colleagues, because that means that we can pool our data. Now, that said, the reason we do a risk assessment is actually to mitigate the risk of TACO. So look at the mitigations that we do. We already do weight-adjusted red cell dosing in the paediatric population. We've been doing that very well for many years. And I wish we did it in the same way for the adult population, quite frankly, but we already do that. There is probably already protocols in place for the use of diuretics, particularly in neonates and transfusion-dependent older children. So what additional would you get from that? Even if we did have a risk assessment, those kind of mitigations are probably already in place. But that's not to say that we shouldn't explore that, and that is something that we've recently discussed and actually we're actively pursuing.
Thanks, Sharran. That's great. I'll pass over to Vera.
Yes, so I'm mindful of the time, so you might just have time for another question. And is a TACO risk assessment needed prior to every transfusion?
Okay, so this is also something that we're asked quite a lot as well. So think about why you are doing the TACO risk assessment. Part of what the decision making is how much blood am I going to give to this patient. So you're kind of deciding that at the outset. So it's very important that it's done per transfusion episode for sure, because it's part of your decision making about overall how much blood am I going to give to this patient in this transfusion episode. So it certainly needs to be done at the outset. But that's not to say it's not good practice then that between units you're going to do your clinical review anyway, that you think about have any of those risk factors changed. So I can't give you a solid answer on that, but certainly it should be done per transfusion episode.
Thanks, Sharran. I'm going to sneak one more question in because I think it'd be really helpful if that's okay. Do we have or do you have any training packages available for pulmonary complications? You've put anything TACO or respiratory related. I know you mentioned there about the patient safety alert, but any signposts you want to give, I'm sure people would appreciate it.
Yeah, I mean, the two things that come to mind would be there is a specific video that's about 8 minutes long on TACO, and there's another one on the pulmonary complications as well, and both of those are available on the resource section of the website. So certainly those two things. I don't know whether colleagues can think of anything else, but those are the two things that come to my mind anyway.
Yeah, we have some webinars as well, Sharran, on the website. And like Sharran said, most of it's on the website. We've actually got time for another question. If
I was just going to do a bit of selfish plugging as well, but we have got the National Patient Safety Alert has gone onto the SHOT website. If you can't find it, please do get in touch. But it's under resources, and then about halfway down on that drop down, there's safety alert. So if you have a look there, and it's at the top of that page, and next to it is also a really good FAQ document. So there's all sorts of information there. There's loads of resources and links and signposts in both of those. So if those things don't answer your questions, absolutely do get back in touch. Have I still got time for a question, Sam?
Just one, if we can have a brief answer from whoever answered it, that'd be great. Yeah, we've got time for one more. Thank you. If we've got any more.
We have got more.
All right.
Let's have a little, I suppose there's a comment here and somebody's agreed with it, so let's ask that. Just as a comment, TACO patients are often, the lab aren't informed, I think is the comment really. Often with HTRs, we're inundated with samples and further requests. So how do we make sure that labs are informed when these cases are occurring out in the clinical area? The comment is often they'll ring the ward and they'll say, oh, that's the TACO patient, yet the lab hasn't been informed. Do you think there's a mechanism or a pathway that people could incorporate?
Well, I think for any acute transfusion reaction, organisation should have a procedure in place to make sure that there is a mechanism of communication. You know, because usually at the end of the bed, it's quite difficult to know what kind of reaction a patient has. You're reacting to a symptom complex, and that should really trigger an evaluation about whether or not this is a transfusion reaction. And I would say that probably most organisations that I've worked in will have some sort of like clinical checklist where you kind of fill it out and it determines whether or not there's been a transfusion reaction and who to communicate that to. I was part of the BSH guideline writing group for the revision of the acute transfusion reaction guideline. And actually, we've made some changes there, which actually simplifies the laboratory process. I know that wasn't quite the question, but I just wanted to say that anyway. But that you might actually find that useful. But I think, it's the initial recognition, isn't it, the really important thing, and for staff to be aware and know how to communicate that.
I think the other thing in the long term is that there was one of the recommendations of the infected blood inquiry was that in future the outcome of every transfusion should be recorded, and what is meant by the outcome of every transfusion has been left to define. But you would think that the occurrence of adverse events would be quite an important part of that.
Thanks, Tom. Thanks, Sharran. So we're now going to put a poll onto the screen for the delegates. Please, if you've got a second, would you like to answer those questions? That would be really helpful to us to give us some feedback. So Darren's going to do that now. Any moment now. There you go. And I'll hand over now to Caryn, who's going to close the meeting. Thanks, Caryn.
Hi, everybody. Thank you all for those great questions, and apologies if we haven't got around to answering your specific question. But if you have anything that you'd like us to answer, please do email us through to the SHOT email address, and we'll endeavour to get them answered for you. As Saya has already said, we have a poll up on your screen. Please feel free to submit your answers. They're incredibly useful to us for informing us for future resources and webinars. We really do appreciate your feedback and comments and suggestions about hemovigilance. So please also give us feedback via the email address. And as Nikki has already said, we have lots of resources and useful things that you can use for your educational activities on the SHOT website. So please feel free to visit that too. For those of you who are not aware, we also have a SHOT app, which gives you access to all the SHOT resources. It's easy and free to download. And it's really great to use at the bedside where you don't have access to a PC. Finally, a huge thank you to all our speakers today, Dr. Sharran Gray, Dr. Tom Latham, Dr. Puneet Malhotra, and Dr. Andrew Bentley. Your time is very much appreciated by us all, and to all the participants and those who registered to attend, thank you all very much for joining us, and we hope to see you soon.
Thank you.